What is the reason for this resurgence of TB that you see in India? What is, we had TB for ages, but why now?
Thank you, Raj. And I think it's a great initiative that India Today is acknowledging the magnitude of the problem. I think one of the biggest myths and lies that individuals tell themselves when it comes to tuberculosis is that it will never happen to us. There is this perception that it happens only to the marginalized and the impoverished. And while it is true that a majority of individuals will fall in that category, we know that there are a lot of conditions which predispose you to tuberculosis. So let's talk about diabetes, for example. So about 100 million individuals in this country have diabetes, and an equal number have pre-diabetes. And if you do have diabetes, there is a strong risk of getting tuberculosis. If you smoke, you have about a 2-fold to a 3-fold chance of getting tuberculosis, and somewhere about 10% of individuals in India smoke tobacco in some form. If you have other lifestyle diseases or non-communicable diseases, such as liver diseases or kidney diseases, that makes you more prone to getting TB as well. So these are diseases very often of affluence. It's not necessarily of people who are impoverished. And as Indians get more prosperous, more non-communicable diseases, it's only expected that TB will also rise. The second issue with TB is that it very often gets diagnosed late. So individuals who cough, 50% of individuals in this country will approach the private sector. The private sector very often will treat you with antibiotic after antibiotic, and the diagnosis often gets delayed a couple of months down the road. And these couple of months is when you go around spreading the disease, unfortunately, to others. So I think a combination of an increase in risk factors in the country and the fact that the diagnosis is very often made late is what's contributing to the resurgence.
And am I right, Dr. Pinto, that 40% of this country is actually infected with TB, latent TB, don't know about it, and the trigger factors are the ones that you mentioned. So 1 out of 2 of us could get TB at any time. That's the point you make.
Absolutely. So TB is a fascinating germ, so you can get infected
right,
and you cannot have the disease.
Yeah.
So 40% of this country is latently infected. If you did a skin test, if you did a test called the IGRA, it'll show you that at some point of time in your life, you've been exposed to the germ has entered your body and is sitting there quietly. And during the course of a lifetime, of all individuals who are infected, about 5% of them will develop the disease. Now, when that transition from latent TB to active TB happens, is usually when your immunity is compromised because of diabetes, because of smoking, because of some other reason. So I think this reservoir of 40% of individuals who have latently infected TB are important, especially when we talk about eradication of the disease. You cannot eradicate the disease unless we somehow manage to eradicate the reservoir as well.
Now, coming to you, Raman Sarkar, one of the issues that we face is in terms of diagnostics. As Dr. Pinto mentioned, many people don't know they have TB for at least 6-7 weeks. And by then, it can be very serious for them. What can we do in terms of speedier tests, firstly? What is available? That's why we titled this the new treatments, new diagnostics. What can we get, instead of waiting 8 weeks for earlier sputum tests, what is the latest that we can do in terms of TB diagnostics?
Thank you, Mr. Chengappa. I think it's useful to reflect where we were around 10 years ago. We were a country which was called to have a missing 1 million or 1.5 million patients. That means that out of the estimated number of cases that are emerging, we are not actually notifying, detecting, reporting 1.5 million. Today, last year, in 2022, we reported 24 lakh TB cases. That means our case detection is improved. And this number was in 2013 or 2014 was around 14 lakhs. So our case detection has improved as a result of, newer diagnostics being used, greater awareness. This city actually gave us the TB Harega Desh Jeetega campaign, which was started by the Mumbai Municipal Corporation. And the city also gave us a model of engaging with the private sector, like Dr. Pinto was mentioning. And this is not only in Bombay, but it's across the country that a large number of people do go to the private sector for care. So it's important that we engage with the private providers, and your private providers are not only the Hindujas and the Apollos and the bigger ones, but these are also the small shops, the informal providers, the chemists. So, creating a network of all those touch points has actually helped us improve the number of notifications we get to the government. And there is a way to go, and, awareness seems to be the greater awareness generation is going to get patients to come themselves and actually get themselves tested.
Now, I think this is where Sudhakar Shinde can come in. Now, Sudhakar, you're also a doctor. You're also additional commissioner for the BMC. What have you all done to, say, contain TB, in terms of both quickly getting them diagnostics as well as treatment? What is, and this could be a lesson for the rest of the country.
So, Mumbai has one of the highest number of tuberculosis cases, as well as one of the highest number of multi-drug resistant tuberculosis cases. So, BMC has done some additional to what Government of India and Government of Maharashtra is doing. So, like Government of India is having strategy of detection, treatment, prevention, and building. These are the 4 pillars of Government of India's anti-tuberculosis policy. So, BMC has, in addition to it, incorporated another pillar of active search. We actively go to the door to door and do the surveillance. We do record the signs and symptoms and try to detect the tuberculosis early. Apart from this, I think Mumbai's higher number of detection of cases is also related to Mumbai pattern, which we call, and this is because Mumbai has its own pattern of collecting the data from private healthcare practitioners. Apart from Mumbai, no other unit has such kind of reporting mechanism. We have something called as patient provider agency, which provides us data and inputs from patients being treated at private hospitals. Apart from this, Mumbai has also depended more on NAT technology for detection of tuberculosis rather than going for routine microscopy, which itself has a higher sensitivity.